Hello everyone, in this video we are going to discuss about cystic fibrosis. It is an autosomal recessive genetic disorder caused by mutations in CFTR gene, that is cystic fibrosis transmembrane conductance regulator gene located on chromosome 7. So the deletion is deletion of phenylalanine at position 508. It is an autosomal recessive condition. Here the pathophysiology is the main defective thing is CFTR. So it functions differently in different areas. In sweat glands, the function is very different from the other organs like lung, pancreas, and liver and intestines. So in CFTR gene, in all these organs, it acts as a chloride transporter. So we know the chloride ion is transported along around, and here the sodium and the water will also follow this chloride. So there will be watery thin secretions. But in sweat glands, the CFTR acts as a chloride resorptor. So there will be chlorine resorption. So same sodium and water also will be resorbed. But if there is any gene defect in CFTR, what happens is in here there will be thick mucus secretions, and here there will be increased chloride secretion. So defective CFTR gene leads into impaired chlorine and water transport, thick viscous secretions in lung and the other organs, and here increase in the chloride secretion in sweat glands. Leads to infection in the infections of lung, malabsorption and organ dysfunction. The clinical features include chronic respiratory illness like chronic lung infection, Pseudomonas aeruginosa infection is more common, bronchiectasis, nasal polyps, distal clubbing. Pancreatic insufficiency can be seen, and there can be deficiency of ADEK, fat soluble vitamin deficiency, meconium ileus in neonates and failure to thrive. And in endocrine related disorders like cystic fibrosis related diabetes mellitus, and fertility problems in males and females. And increase in chlorine loss here because of this sodium and water is also lost in sweat glands, so there is risk of hyponatremia. So simple test is in sweat chlorine test, it is more than 60 millimoles per liter is gold standard. Genetic testing can be done. Newborn, there is immunoreactive trypsinogen levels are more, that is IRT levels are more. This is because the trypsinogen which is produced in the pancreas, it is converted into trypsin, but this is hampered because of the pancreatic ductules blockage. Because of the blockage, the trypsinogen levels are directly released. Trypsinogen is directly released into bloodstream. So there is increased levels of this immunoreactive trypsinogen. And pulmonary function test shows obstructive pattern because of the blockage of the bronchioles because of the mucus. So we can give physiotherapy, mucolytics like Dornase alpha, inhaled bronchodilators, hypertonic saline, antibiotics for infections, ivacaftor, lumacaftor. These are CFTR modulators. So we can give supplementation of the pancreatic enzymes, fat soluble vitamin supplements, high calorie diet. And lung transplantation is done in advanced cases, and genetic counseling should be done to prevent further diseases. And survival is 40 to 50 years with treatment. It is a progressive disease. So takeaway points are in this class, there is CFTR gene mutation, chromosome 7, phenylalanine deletion at 508 position, autosomal recessive condition. So CFTR causes thick secretions because of the chloride transport impairment, and there is increase in the chlorine secretion in the sweat glands. 60 millimoles per liter is diagnostic, and it is gold standard. And increased immunoreactive trypsinogen in newborn screening we will do with heel prick test.